Hello and welcome back to the channel. My name is Dr. Tanmay Gautam and today we are going to be presenting the topic on fungal rhinosinusitis. This is a lecture that I am creating as an ENT resident for other ENT residents, so feel free to tell me if you need anything changed or if I made any mistakes. Now, introduction. There are two broad groups based on the presence or absence of fungus in the tissue, such as the mucosa, blood vessels, or bone. Now, this can be invasive or non-invasive. Today we are going to be focusing on a non-invasive. Non-invasive fungal RS. So what are the types? First, it is saprophytic fungal infection. So what happens is a patient undergoes a surgery which causes dysfunctional mucociliary clearance. After dysfunctional mucociliary clearance, the patient is not able to clear his mucosa very efficiently. This causes buildup of plugs and crusts. These plugs and crusts serve as a very fertile soil for fungus, and fungus grows there exponentially. This can be visible in the nose and the paranasal sinus or nasal endoscopy, and they can be asymptomatic, or the patient can have foul smelling odor, which is also known as cacosmia. Uh, these are precursors to fungal ball, the disease that we are going to be studying next. And the treatment is endoscopic removal of the whole crusts and then getting many washes to the patient, nasal douching as we say. Now, fungal ball. Fungal ball is a dense accumulation of extramucosal fungal hyphae. So these have not invaded anywhere, right? Most commonly, the maxillary sinus is involved, and only one sinus is involved, as it is a limited disease. This occurs in immunocompetent on individuals, such as those that have ability to concentrate the whole disease in that area and not allow the disease to spread further. So maybe if the disease is spreading this way, the host's immunity will try to prevent it, and it will say, okay, don't go further from over here, and so they will ball the whole thing. So thus the disease is known as fungal ball. Okay. So the most common organism involved is aspergillus. Most common sinus is maxillary sinus. They have a very high predilection for post dental procedures. So there can be dental procedures which can have infiltration of some kind of fungus during the procedure, or due to a cavity effect that can be present there. The fungus can have a very good area to grow. So dental procedure history must be taken. Now, how does a fungal ball look? This is an orthopentogram. So here we can see in the lower part of this maxillary sinus, you can see this whole region. This is you can see this should be black, right? So here you can see an opacification, and you can see there's a bulge here as well, right? So that's a fungal ball. Radiologically, the sinus opacification we have already seen. Now we will see hyperattenuation. See, what happens is when fungi they grow in a certain region, they grab iron, calcium, and manganese, and that's why these areas of hyperattenuation can be seen. This we will also read in the coming chapter in double density sign. Endoscopically, there is cheesy or clay-like debris, which uh, which is present inside the sinus. There can be inflammation, but it is non-specific, and there is absence of any allergic mucin. So allergic mucin is a characteristic presentation in AFRS, allergic fungal rhinosinusitis. It is not present in fungal ball. And similarly, AFRS and its own brother, the one that we will be reading later, they have a high eosinophil count. So eosinophil count will also not be high in this case. Microscopically, you can see fungal hyphae, and there won't be any tissue invasion. This is the fungal ball on endoscopic vision, and as you can guess, our job is to remove this whole fungal ball as clearly as possible by using these angled endoscopes like 70-degree, 30-degree, 45-degree, and then we can use these nasal douchings and nasal sprays, but oral or topical antifungals are not necessary. Now, this is the crux of the chapter: fungus related eosinophilic fungal rhinosinusitis, including AFRS. Okay, so the name itself is signifying what we are reading: fungus related eosinophilic. So remember, the patient will have eosinophilia, or the patient will have mucus that will have eosinophils, right? And then this is rhinosinusitis, and this includes allergic fungal rhinosinusitis. First, we will start from here. So what is allergic fungal rhinosinusitis or AFRS? It is non-invasive fungal sinusitis resulting from allergic and immunologic response to the presence of extramucosal fungal hyphae in the sinuses. Okay. So large definition, but we can remember it in parts. First of all, what is it a type of? It is a non-invasive fungal sinusitis. So this is clear. And it results from allergic and immunologic response to extramucosal fungal hyphae, which are in the sinuses, since the name already has sinus in it. So these were considered to be just like allergic bronchopulmonary aspergillosis, like that aspergilloma forms in the lungs. So the doctors then thought these are what form in the nose. These are caused by the dematiaceous fungi, which are known as bipolaris, curvularia, alternaria, which are more common than aspergillus. I will show you the images. This curvularia has these curvy long thread-like hyphae, and alternaria has these alternations, and these alternations are what give it the name. Bipolaris, since it is bipoled spore, and then helminthosporium and other organisms are also there. Dematiaceous fungi are fungi that are darkly pigmented due to melanin in their cell walls, and these are molds, these are not yeast. Now you have to remember that FRS is it can present with the chronic rhinosinusitis as well, and patients that go undergo surgery, they can develop fungal rhinosinusitis later. Here we can see 12 to 47% that undergo treatment for chronic rhinosinusitis develop FRS, fungal rhinosinusitis. Now AFRS is the most common form, which is 56 to 72%. AFRS is what is the main crux of non-invasive fungal rhinosinusitis. The frequency male is to female, it is more common in males, right? So pathophysiology, see, this is the main point, that there are three pathophysiologies that we will be reading. First, Manning et al. So what he said was just like ABPA, they are saying that raised fungal IgE is present and IgG antibodies in AFRS patients. So this must be that the patient is developing a type 1 and type 3 hypersensitivity response to the allergic fungi, to the specific fungi that he's allergic to, and then this response is what is creating the whole problem. But if the disease is a type 1 or type 3 hypersensitivity reaction, it should involve both of the sinuses at least, or it should not be a unilateral disease. And mostly what we have seen is AFRS is unilateral, right? Then persistence of raised IgE levels even after you have given fungal immunotherapy, because what happens in immunotherapy is that IgG blocking antibodies, they should form, and the specific IgG levels, the failure of a rise in specific IgG levels, if you form IgG and blocking antibodies, so then the specific IgG levels should rise, but it didn't rise. So therefore this Manning et al was not agreed upon. Then Panica et al came. Here you can see it was like this eosinophilic chemotaxis is what he said. He said that the mucin that is present in AFRS, that is containing eosinophils, and so he named the disease eosinophilic fungal rhinosinusitis because this eosinophilic fungus was present, and he changed the name from allergic mucin to eosinophilic mucin. But it did not explain how the chemotaxis occurred. Why is the eosinophil in the nasal mucin? Then came Ferguson. So Ferguson said that there are two disease processes. First is the eosinophilic mucin rhinosinusitis. This is not allergic. For some reason, eosinophils and mucin, eosinophils are present in the mucin of the rhinosinusitis patient in EMRS. These have AFRS like features, except fungus is not present, right? So this is one disease that he has classified. Then the other disease that he is saying is AFRS itself, where all of the features of AFRS are present along with fungus. Now systemic, the whole body has the response of immunological controls, and so lower and upper airway eosinophilia occurs. These are two separate diseases, but they end up in the same symptomology, right? Antifungal agents and fungal immunotherapy should theoretically benefit only AFRS and not EMRS patient, right? So that is what they thought, but they end up benefiting both, right? Now, Bent and Kuhn criteria, this decides if the patient is a case of AFRS or not. 5 major criteria, you only have to remember the major criteria. Minor criteria are only supportive, they don't play a very big role, right? Even if you have all 6 minor criteria and no major criteria, you can't diagnose the person as allergic fungal rhinosinusitis. So how do we remember all of these? So I have prepared this mnemonic. It is PDD1MF, right? We know PDD is a singer, right? And he had some scandal recently, so he became 1MF. We know what MF is. So P for polyps, D for double density sign, 1 for type 1 IgE, M for mucin, which is eosinophilic, and then fungal smear, right? So if you remember all of this, it will be very easy to diagnose. So PDD is 1MF. There exists a subgroup of patients that do not fulfill the Bent and Kuhn criteria, for which this new criteria was proposed by St. Paul Sinus Center. Right, so one is Bent and Kuhn classification, one is St. Paul Sinus Center diagnostic criteria. So this is also having the same mnemonic. So we were saying PDD is 1MF, now PDD is MF. That is the only difference. So PDD is immunocompetent, since we know that IgE and type 1 response is no longer favored. So we won't say that the patient must have IgE response or must have type 1 response. So immunocompetent is what we have included in this. Polyps, double density, which is found on CT. An immunocompetent patient with mucin which has eosinophils and a fungal smear. This will be the criteria. But you can't say that okay, this symptom is present in this patient, so then that patient has AFRS. There are no pathognomic symptoms, except there is a very strong linkage between this allergic mucin and AFRS. So in a young patient with unilateral or bilateral nasal polyposis, the patient will have thick, sticky yellow-green mucus, which you can see here. This is known as axle grease mucus, also known as this peanut butter mucus. So I hope you're not eating anything. So characteristic double density sign is seen on CT. We already know PDD. So DD stands for double density. These patients respond well to oral steroids, and this peanut butter, you have to clear all of this, because this is the source that serves as the antigen for the immunologic response. Now what are the immunological tests that we can do? First, IgE. So IgE will be elevated, but it has a wide range. See, it can be 50 to more than 1000. Okay, so then the normal range between 0 to 150. So 50 to 100, maybe if it's 100, you can't say that the patient has AFRS just by that. Then we're talking about total serum IgE levels. This helps, but it's mostly for monitoring. It only tells us, okay, that this patient is improving or this patient is not improving, right? Now, in vivo skin prick testing and RAS test, this is also present, and this is for fungal specific IgE. So you have to take a specific antigen from that fungus that you think will cause the disease, is causing the disease, and then you have to identify it. So it's a little tricky, but then it can be done. Now let's talk about the CT features. This is very important from the treatment perspective. So heterogeneous signal intensity, there will be one signal which would be clearly see, I'll make it here. So that there could be a isoechoic lesion over here, and then there would be a darker lesion, right? So this is what is the double density sign. I just showed you that image before, just like that. Now expansion of the paranasal sinuses and nasal cavity, unilateral asymmetric disease load. That is why we didn't agree with Manning et al, right? And there could be bony erosions. So now I'm going to show you the video. This MRI will be covering in the next slide. So here I will just play the video. Just 1 second. So here you can see this whole region has the disease processes, right? So that is the whole region that is involved. You can see there are many different grades. There's the frontal sinus which is involved. Then here you can see this area is a little hyperdense. Then most other areas have small areas which are hyperdense and isodense. Okay. So this is the double density sign that you just saw. Okay. And you can see there is expansion of this nasal sinus, and it is unilateral, it is asymmetric, there is bony erosion present here. So this is a very good CT for looking at it. Now we are going to see it in the coronal sections. So here you can see these densities. Here you can see this density which is changing, right? So this sinus is also expanding, osteobetal complex is expanded. Now here you can see the frontal sinus involvement. All of the sinuses are involved on this side, right? Here you can see the maxillary sinus. All of the bones here are eroded. Even the alcinate is not visible right here. Frontal sinus is visible. All of this double density you can see. Okay. Now let's talk about the MRI. So MRI is already done when you have to rule out that any other malignancy inside the brain or orbit, since what we just saw can mimic some certain conditions of erosive sinonasal malignancies. So if you have to rule that out, you can do these tests. So MRI T1 weighted has low intensity, but T2 has even lower intensity, so that there will be signal void. So basically you will be seeing some lesion in a specific area, and when you will be shifting from T1 to T2, that lesion will be absent. Okay. This is you can also see some concretions that have high iron and manganese, like we were talking before. But this signal void is something this is very important. So first that lesion is present, then that lesion is absent. Don't worry, I will show it to you. Right. So here you can see, look closely at this area, right? So this area, you are seeing something. There is something present here. You can see that, right? Now I will now changing that. Here you can see that signal void is present. What you were seeing before is now absent. So how did that happen? That happened because of the change in density. Since this is mostly protein and fluid present here, so that area has signal void. Now the hallmark of AFRS is this allergic mucin that we were talking about, this peanut butter and axle grease. What does it have? What is it made of? So it contains eosinophilic mucin, which has necrotic eosinophils, inflammatory cells, and Charcot-Leyden crystals, and fungal hyphae. So Charcot-Leyden crystals, what do they look like? They look like straight pinkish jagged shards. Okay. And fungal hyphae, I just showed how they look. You know how any eosinophil looks, right? Now how to view the fungal hyphae? So Grocott and Gomori methamine silver, these are silver stains for fungal hyphae. They can allow you to see it. So you have to remember this, Gomori methamine silver. Now positive fungal culture, these are supportive as we see, but you can't make a diagnosis just by that. We have seen the Bent and Kuhn and the St. Paul's criteria, right? Histological identification of allergic mucin, you can help. This helps in the diagnosis, but it's not a compulsory diagnosis. So how will you manage this patient? So first you have to clear the disease. Surgery is the main first line treatment, and then after you have performed the surgery very well and removed all of the polypoidal disease, the allergic mucin, and you have now made a good ventilation and drainage for the sinuses, then you can go ahead for the medical management. But you should get benefit from the image guidance system. This is available outside, but it's not available in India. I don't know about this. Maybe it's available in big tier 3 tier 1 cities, It's not available here in our tier 3 city. It eliminates any antigenic factor after you have removed all of this disease. I told you antigenic factor is present in the eosinophil mucin and the fungal hyphae. So you have to remove that. Then it gives wide access for surveillance. Then you can debride it. Then you can have the medications which can go inwards. Now after you have performed the surgery, you have to follow the case. Now for follow up, you have two criteria that you can use. First is the Kupferberg. So Kupferberg, he had a post-operative finding that if it is normal nasal mucosa, it is stage 1. If the mucosa is edematous, then it is stage 2. If polypoidal edema, then stage 3. If allergic mucin is present, then we have to check if either of these is present or not. And if there are frank polyps or fungal debris, then it will be stage 4. Right. So what they found was this was not very sensitive. So they changed to Philpott-Javert system. So Philpott-Javert system, what it does, it divides it. It divides the whole sinus cavities into the 4 parts: frontal, ethmoid, maxillary, and sphenoid. This is for the right, this is for the left. If you have any kind of edema, then that will be mucosal. If it's just a mucosal edema, which can be divided into mild, moderate, severe. I will show you the images after this. And then polypoidal edema, which is mild, moderate, and severe. And then frank polyps, which can be mild, moderate, and severe. So this has been divided. So if it is a moderate frank polyp, so that would be 8. And if it is present in the maxillary region, that would be 8. The total comes out to be around 100. Okay. So the out of 100 we give the score. This patient is currently in this condition. Okay. And these are the images. If there is no edema, this is how it will look. If there is a mucosal edema, we can see there is some congestion, but there is no clearly identifiable vessels or inflamed mucosa with edema. Here you can see there is a marked mucosal edema, and this is the most severe mucosal edema. You can see whole of this area is inflamed. Then you can have polypoidal edema. Here we can see there is polypoidal changes, but there is no polyp visible. Then here we can see small polyps are beginning to form, but nothing large. Here we can see a large polyp is beginning to form just behind this area. Okay. Now frank polyps, this is frank polyps. Here you can see this large polyp is visible, and here you can see this, it is almost the size of the middle turbinate. Now medical treatment of this disease, it is mostly for perioperative care. Corticosteroids, see Landsberg, he studied preoperative corticosteroids, and he said that if you give preoperative corticosteroids, that reduces intraoperative bleeding. Then Kuhn and Javert, he studied. This is the same guy. He gave the Philpott and Javert. He is still doing him. And Bent and Kuhn, this is also that Kuhn. So they say reduction in IgE and mucosal disease post-operatively in cases where they gave 6 months of corticosteroids. So that is a very long treatment for corticosteroids. We know that this will cause some sort of side effects. So we have to be very careful. In perioperative period, we can give short courses, but you can't give those prolonged treatments. In recalcitrant cases, you might have to. Now fungals. Now we use these as steroid sparing medication in recalcitrant AFRS. Benton Kuhn said that oral itraconazole, that has the best steroid sparing effect, because it takes over the clearance of the disease from the steroids. Okay, so you can use this instead of steroids, and most of the side effects that itraconazole causes are just that they elevate the LFT. After you stop itraconazole, LFT will then become normal again. Also, it can have a few side effects such as edema in some area, but that will also resolve, right? Some patients respond well to antifungals. We don't know why. We have to find out. Now, topical medications. Corticosteroids topically are most effective, and they are used post-operatively to maintain the treatment of the patient, right? So there are various metered dose nasal sprays such as mometasone, fluticasone, furuate, budesonide. Budesonide is also available. Then beclomethasone dipropionate, ciclesonide, flumisonide, and then triamcinolone. this is something that the author is using in their area. Okay, so this is budesonide nasal drops. What they do is they take this pulmicort, um, budesonide, and they fill it inside this syringe, and this is an atomizer. This is called MAD, mucosal atomization device, and then they put it inside their nose and they spray it. Okay, so this is not FDA approved, but it is being used and it is causing people to have benefits. Side effects is just that we don't know the systemic absorption. Although they have done the trials for this HPA axis suppression due to these drugs, and they have found that it doesn't cause much HPA axis suppression. Okay, but this prednisolone can also be dropped. The Ciplox D ear drop, ciprofloxacin and dexamethasone drop, that has also been used, and that has also given good results. So the budesonide rinse that they are using, that they are doing in this position. This is one of the Mygind position. So they have done a study in which the vertex down top, it is known as the vertex to floor, VTF position, where see, this is the head and this will be the vertex. So the vertex will be to the floor, so it will be a much more hyperextended neck. But they are saying just a lateral to floor location is also good, and it's good enough to supply all of the frontal and ethmoid sinuses with this solution. And they have performed a study in which they found the same. This is another antifungal, but this is something, now here we are going into the experimental area. So antifungals spray, ketoconazole and antifungal spray, where they've used fluconazole, they've used itraconazole, they've used mixed combinations, and they have seen that fluconazole nasal spray can be used, and they reduce recurrence rate, and using those spray the recurrence rate stays under 10%. And then itraconazole and topical fluconazole together, they cause 14.3%, and then so on and so forth. You can read these statistics, right? Another thing that is being used is immunotherapy. We have had 10 studies where Deshazo and Hall performed a literature review, but they were non-conclusive, and there is no big RCT. Okay, adjunctive treatment, this Manuka honey is something interesting. So Manuka honey they are using, which is found in New Zealand. It has broad spectrum action against many organisms such as gram positive and gram negative bacteria, and this is because of the presence of methyl glyoxal. Methyl glyoxal is the active agent, and this Alan Dejani patient guy, he found that 33% weight by volume of Manuka honey, it works against biofilms of Pseudomonas, methicillin resistant and methicillin susceptible Staph aureus. So all of those biofilms that we deal with so direly, those can be treated with Manuka honey. I wonder if it works in the ear as well. Then this is the treatment. This Manuka honey they have shown. They also say that Manuka honey causes improvement in people who don't show improvement with any other treatment. 21% patients, they showed improvement. They are also using omalizumab. They are saying that 16-week omalizumab treatment, it causes reduction in the symptoms in nasal polyps and asthmatic patients, and it is present irrespective of any allergy. Okay, so that is it. That is all we have for today.